Okay, Miranda, am I ready?
Yes.
Great, okay. Hello, everybody. My name is Cliff. I'm the Associate Executive Director at Access Alliance Multicultural Health and Community Services. I would like to welcome you today to our webinar that is entitled Tackling Stigma, the Unresolved Barrier to Achieving Good Health, a panel discussion. In front of you on the screen, you see the photos of the 5 people who will be participating in our panel discussion today. In a moment or two, we'll introduce the panelists and they'll be able to say hello to you. Panelists, if you could also let us know your preferred pronouns as you say hello, that would be really great and helpful for the webinar. Okay, let's go on to the next slide, Miranda, please. So we have a land acknowledgement, and I will read this through for all of us. So we acknowledge that we as individuals and community groups continue to benefit from living in Toronto, known today as Toronto, on lands that belong to many Indigenous nations, including the Huron-Wendat, the Anishinaabe, the Haudenosaunee, and the Mississaugas of the Credit. As an organization with a mandate to work with newcomers and as individuals and communities who have come here as settlers, immigrants, newcomers in this generation or generations past, as well as those of us who have come here forcibly, particularly as a result of the transatlantic slave trade, we recognize the ongoing impacts of colonialism, as well as the resilience and resistance of Indigenous peoples and nations across Turtle Island. We are all treaty people and are thus responsible and accountable for peacefully sharing and caring for the Great Lakes region. We commit to addressing and opposing any and all colonial violence and strive to practice solidarity with Indigenous peoples by listening, learning, building relationships, and taking action. Okay, Miranda, if we could go to the next slide. So here are our panelists, and let's just take a couple of minutes for each of the panelists to say hello, to tell us their agency, preferred pronoun, and then we'll move on. Nadine, can we start with you, please?
Sure, Cliff. Hi, folks. Nadine Sukermani. I'm the Executive Director at Fife House. And when my slides come up, I'll tell you a little bit more about Fife. My preferred pronouns, or my pronouns, sorry, are she, her.
Great, thanks, Nadine. Anna, over to you, please.
Oh, Anna, you're muted. Sorry.
I'll do it all again. Not off to a great start. Hi, everyone. My name's Anna. I am the program coordinator of the Teens Educating and Confronting Homophobia program at Planned Parenthood Toronto, and I am pronoun ambivalent.
Great, thank you, Anna. Tuana, over to you, please.
Good afternoon, everyone. My name is Tuana Austin. I am a member of the now concluded Access Alliance TB project, and I'm also a PhD student at the University of Toronto, as well as the manager of the Assertive Community Treatment team at Summit Housing and Outreach Programs.
Pronouns, Tuana?
Oh, great. Thank you. My pronouns are she and her.
Great, thank you. Kyle, over to you, please.
My name is Kyle Arnold. I'm an outreach worker with Norwest Community Health Center, and my pronouns are he and him.
Great, thank you, Kyle. And Mandana, over to you, please.
Thank you, Cliff. Good afternoon, everyone. My name is Mandana Wahabi. I'm from Ryerson University at the School of Nursing, and my preferred pronoun is she or her. Thank you. Great,
thank you, Mandana. Okay, let's move on to our next slide, please. So a little bit in terms of what brought us here today. Access Alliance about 2 years ago received funding from PHAC, the Public Health Agency of Canada, to do a little bit of a study on access to TB care for newcomer populations. At the time, we believed that stigma was going to be an important part of that study in terms of the influence, the impact that it had on the support and care available for people who may have tuberculosis. We also saw that the impact of stigma related to other illnesses and conditions came up again and again as we did our work at Access Alliance, notably HIV/AIDS, COVID, addictions, cervical cancer. Those were other conditions and illnesses that where we noted stigma certainly played a key role. We also saw throughout our study that people were in effect having to deal with a medical illness or a medical condition, as well as dealing with the impact of stigma on their access to care, and in fact, the care that they may actually have received within or throughout the healthcare system. So today, we have an opportunity to explore the effects of stigma across a broader spectrum of conditions and the communities that are affected by those conditions. So we'll hear about the impact of stigma on people, the care that they receive, as well as the practices that reduce the impact of stigma as a barrier to good care and support. We should also have a little bit of time near the end for any questions or discussions. Okay, next slide, please. Just a little bit in terms of, what is stigma? Now, some of the panelists will also be looking to define stigma in relation to the populations that they provide service to. But briefly, we know from various dictionaries that stigma is a mark of shame. It can be a mark of discredit, disgrace. It's considered to be a stain or a reproach on somebody's reputation. It's something that detracts from the character or reputation of a person or a group. It is public disapproval of something, such as an action or a condition. It's also something that may not be considered normal or standard. Some of the synonyms for stigma include words like blot or brand, slur, smirch, smudge, spot, stain, or taint. And you can see, as we look at definitions of stigma, you can see that particular themes are coming up in what stigma is and how it can negatively affect an individual or a group of people, or how it can brand a condition or an illness. In modern use, the scar is figurative. It often refers to a set of negative and unfair beliefs that a society or a group of people may have about something. People talk about stigma associated with mental illness or the stigma of poverty or any of the conditions that that our panelists are going to be talking about today. So that's a little bit of background in relation to what brought us to the panel discussion and the webinar today. So first up in our panel is Nadine. Over to you, Nadine.
Oh, were we going to let Jason just have a few
Oh,
words?
absolutely. We are going to do that. Nadine, I'm putting you on hold for another second. Jason Rahal, who is the communications manager at the Alliance for Healthier Communities. Over to you, please, just to give us a bit of welcome from the Alliance and a minute on Community Health and Wellbeing Week, please.
Thanks a lot, Cliff, and thanks a lot to Cliff and Miranda and the rest of the Access Alliance team for coordinating this webinar series this week during Community Health and Wellbeing Week. This year's theme, which you'll see up there in the top left-hand corner of the slide, is Building Equitable Futures. And this is a theme that you'll see throughout the rest of this year and into 2022 as the Alliance and Access Alliance, of course, 107 other members across the province providing comprehensive primary health care are all celebrating Community Health and Wellbeing Week this week with that same theme. And we'll be carrying that theme well into next year with the election coming up and trying to get more health equity priorities onto the provincial agenda. All I encourage everyone on this webinar to do today is please, if you've learned something new today, if you've taken an insight, please go and share that on social media, whatever platform you happen to use, Twitter, Facebook, Instagram. I know Facebook and Instagram are down right now, but certainly Twitter is still up. And please use the hashtag CHWW2021, and that way your comments and your insights and your experiences from the week will become part of that that tapestry of everyone else's experiences across the province, because there are lots of other webinars and interesting events happening across the province. But I'd like to welcome everyone and thank you for your interest in this topic, and also, of course, 2 other webinars coming up this week that I'm sure Miranda and Cliff will talk about on language and on housing and LGBTQ. So thanks a lot for being here. That's all for me.
Great, thank you, Jason. If I keep making mistakes like that, I will never be asked to host the Tony Awards. Now, Nadine, over to you, please.
Thank you, Cliff. Thank you, Jason and Miranda as well for bringing us all together today. So as I mentioned, I'll just share a little bit about Fife House, maybe not very well known to folks, but again, I think it's important, and I want to thank Cliff for including HIV as part of the spotlight on this, in this particular panel. It is a disease or a condition that people don't pay a lot of attention to anymore. The idea that HIV is a kind of something of the past is something I'm hoping also to bring to your attention today. So at Fife House, we actually house people living with HIV across the Greater Toronto Area. Our vision is that everyone living with HIV/AIDS has the right to quality, stable homes in a society free of stigma. So the word stigma itself is right there in our vision, which is why I thought it was important to share that with you. Miranda, you can move to the next slide. Sorry, just a bit more about Fife. In the last year, Fife House, even in the middle of a pandemic, housed over 109 people, all individuals living with HIV across our system. We served over 850 unique clients who are living with HIV and homelessness. So that's actually the intersecting driver of our work. Overall, Fife House houses over 350 people across the Greater Toronto Area. So those numbers might be surprising to you, again, because HIV, who knew, 2021. But as we talk about stigma, and again, because the reason the word stigma exists still in our vision is because it is something that people across the spectrum still live with. So HIV stigma, you'll see a definition there. It really refers to, much like what Cliff had already said, negative attitudes, behaviors, and judgments towards people living with or at risk of HIV. The word I'd like to add in here, though, is also irrational. It's also an irrational attitude. It is not based in anything, any science at all. And what it does, in fact, it negatively affects the health and well-being of people living with HIV. And the outcome of that is it discourages them from being tested, from accessing treatment and staying in care. So I really wanted to frame the rest of our time together, or my time with you anyways, around that. Actually, you know what, Miranda, let's jump to that video. I have a video here. It'll just mean you don't have to hear me talk about things as much as the video, I think, really illustrates the current situation around HIV stigma in North America.
As a young person, I see HIV stigma as very harmful to our community. It instills fear in people.
I think a lot of it's fear. You don't know what HIV is and you're scared. Well, it's hard. I was born with HIV.
My brother was HIV positive. Somebody that contracted HIV by sharing needles.
I am not only surviving but thriving with HIV for 29 years.
It's not the HIV that we're fighting, it's the stigma and it's the shame, and You know, those voices that tell you that you can't do it.
Living with HIV stigma is kind of like carrying a burden.
Stigma can be very hidden, and people can perpetuate stigma without even realizing it.
El estigma es como el aire. Tú no lo ves, pero lo sientes.
Stigma can hide in small places, such as being afraid to have your hair cut by somebody who is HIV positive.
People assuming that you have HIV because you're a young Black gay man.
I know for a fact that my mom was afraid of being stigmatized as a mother of somebody who's HIV positive while she is negative.
It's the dating scene, it's the hookup scene. To have your own people, so to speak, ask you if you're clean or dirty, you know, it's sad, very sad.
I see a lot of my friends and peers and people that I love going through these things with their families and not having an accepting family and finding that family in us as friends.
There was a lot of people who played a role in my support as when I got diagnosed 21 years ago and still today.
And I started finding these different communities of people living with HIV or people impacted by HIV, and that's really helped me.
So to have that support, it makes you laugh and smile more and enjoy life so much more.
I'm trying to transform my life. That's why I do this.
Even if you perhaps will never be at risk yourself, you can think about how you can decrease stigma in your everyday life.
Just having that open communication and that conversation, I think as easily as people talk about sports at the dinner table, you should be able to talk about HIV at the dinner table.
Sometimes just by your being open and honest, you may have an impact on that other person.
Addressing HIV person to person can be more of a humanizing experience. They feel more of a connection to you and what you're saying, and that you actually care.
To address stigma in the community, it all comes from having the conversation to begin with.
We can live with HIV. We have the medicine to prevent its transmission. We have the medicine to keep people from getting HIV.
People do live with HIV, and I can live with HIV.
HIV is just a virus. It's the stigma that's the deadly disease.
I think that we need to get people comfortable talking about HIV in order to end stigma.
The opportunities to educate is what gives me hope.
If I educate you on what HIV is and you see like this beautiful person in front of you, then what's the issue?
You're not my friend with HIV. You're my friend.
Help stop HIV stigma in your family
and community.
When we support people living with HIV,
we make it easier for them to stay healthy and live full lives.
Let's stop HIV together. Learn how at cdc.gov/together.
Thanks, Miranda. So the reason I asked Cliff and Miranda if we could show that video right off the top, thanks, was really because I think it touches on a few things. One is, of course, the diversity of people living with HIV. It is no longer, well, it still is, but at the same time, no longer simply a disease or a condition that affects white, gay, cis men. And what we're seeing, and actually, I think we can jump to the next slide, Miranda, thank you, is really who this particular, who this impacts disproportionately. And the reasons that it does that. As I mentioned, you know, HIV stigma discourages people from being tested, accessing treatment and staying in care. And in our case, accessing housing. So we've heard from members of the Indigenous Black newcomer communities, for example, that, well, we don't know that we want to live in a building where, you know, only people living with HIV live in. That stigma is what is going to, you know, knowing that it's, let's say on Church Street or Jarvis Street in Toronto makes them out in the community. And then that stigma connected to, and I think this is where the complexity of the groups you see on the screen come together, is that it's not just about racialization or being part of the BIPOC community, Black, Indigenous, or racialized community, but also potentially being part of the queer community, being part of the trans community. So how does sexuality and one's sexual orientation intersect with HIV, or the assumptions of such? So we heard from a couple of folks in that video where they said, I was born with HIV. That's a group of individuals we don't hear from very often. And so what happens is people are hesitant to disclose because they are concerned about how one will judge them. And we're often hearing this is coming up for people as they access housing, as they access healthcare services. And in many cases for the homeless population that we work with, that lack of access to their medications or to primary care will then put them at risk of not being in the undetectable framework. They will be, their CD4 counts, for example, will drop. And so this then can cause other health comorbidities and issues to come up for folks. And then you're in a cycle whereby not wanting to access the healthcare system is exacerbated. It gets bigger and bigger and bigger, and the issue becomes more and more prominent. That hesitancy to engage with the healthcare sector, we heard, in fact, over the last year and a half with the COVID pandemic, for example, a lot of the talk of positive talk, of testing, really put people living with HIV back in the closet, for lack of a better term, or it created or brought up for folks that the feelings around not only stigma, but also that internalization. So we were seeing that individuals were naming their concerns about interacting with the healthcare system. One of the positive pieces, and I think Cliff and I were engaged in this work, was prioritizing people living with HIV, for example, in the vaccine rollout. But there was still a hesitancy, especially for Black, African, Caribbean, and newcomer communities, as well as people who use drugs and sex workers, because by disclosing or by talking about their identities, we were seeing judgment. We saw, in particular in Toronto, individuals were accessing a clinic specifically in the early stages of the vaccine process. And when asked about why they were there, why were they accessing, what category did they fall into, they self-disclosed that they were HIV positive and experienced some pretty poor treatment as a result. So that's in 2021. And I think it's important to take that into account. So for me, it is about that intersectionality is absolutely a byproduct of a racist healthcare system, a system that has excluded, that has judged, that has made assumptions and has excluded people based on their race, based on their profession as a sex worker, based on their sexuality. And I wanted to add that lens around disability, keeping in mind that people who live with disabilities interact with and connect with the healthcare system more often than the rest of society. And though negative experiences with the healthcare system are episodic for a person living with HIV who presents in a particular way, when you add the complexity of these identities, that episodic nature actually increases. And so you'll see their interactions, they'll be experiencing racism alongside that piece around their HIV status. The last couple of things I just wanted to mention, because I actually have no idea how much time I've taken up, is, there are some really great studies. I've included some resources for you folks after the panel, but one around gender. The Canadian HIV Women's Sexual and Reproductive Health Cohort Study talked about 67%, and this is in Canada, of women who were part of the study experienced rejection when their HIV status was disclosed to their partner. So I'm talking about systemic issues, but it does also get personal. That the personal experience is that that rejection, again, is real. We heard one of the participants in that video talk about clean and dirty, that experience within their own community. So that internalization of that stigma has real serious implications, and that is around mental health. It's certainly around people, we see alienation and isolation, so high levels of that. And despite good HIV outcomes today, the reality is that that internalization is there. So once you believe the stigma, you internalize the stigma. And then the last one I wanted to talk about before we go to the next slide is just that stigma in some parts of our country are driving high rates of HIV. One example is Saskatchewan, where there is a high percentage of Indigenous people who, again, are not accessing testing, are not accessing the healthcare system for good reason. They're not accessing treatment, and they're staying outside of the community. And that stigma is driving less testing, it's driving higher rates, and that intersection of identity with the what is available to them. And there are lots of services available in that province, but because the mainstream healthcare system still makes assumptions about, for example, Indigenous women, today is a day that we're remembering missing and murdered Indigenous women and girls, many of whom, and not all, but many of whom have talked about, and their families talk about the assumptions made about them and the work, and for example, they may be engaged in. So how does that come into play when we talk about HIV? And so Miranda, let's just go to the next slide, and then I'll hand it over to the next speaker.
Actually, Nadine.
Oh, we don't have it. Okay.
No, we do have it, but let's hold that slide.
Sure.
That's a little bit about shifting the discourse. Let's
Yes.
go on. Let's put you on hold for a second. Let's go on to Anna Penner to talk to us a little bit about stigma and trans care, and we can save some of the shifting the discourse pieces for the last section of the webinar.
Perfect. Wonderful.
Great.
Thank you. Thanks, everyone.
Okay, Anna Penner, over to you, and talk to us a little bit about stigma and trans care, please.
Sure, absolutely. So hi again, everyone. I'm Anna, and I'm here with Planned Parenthood Toronto. Just a couple of disclaimers before I start. First of all, I'm here speaking about trans care, but I definitely wouldn't consider myself a trans expert. I think trans folks accessing care are the true experts in their experiences, their knowledge of stigma, and what that feels like in their bodies. While I do identify as non-binary, I also experience significant cis privilege and recognize that when accessing healthcare settings. The second disclaimer is that Planned Parenthood Toronto works with youth 13 through 29. So when I'm speaking about some of our research, some of the work we've done within trans and non-binary communities, I'm speaking about youth, but I really do think that these topics apply to people across the lifespan. So one of the best sources of information on trans experience is in Canada, when we're talking about research, is TransPulse. TransPulse began as a survey in 2009, 2010 across Ontario, and it looked at the experiences of trans folks from a number of different realms, including healthcare, including access to services, including interactions in public, safety, violence, family, many different things. And that survey was expanded just in 2019 to be a nationwide survey of over 2,000, actually 2,873 trans folks across Canada. And the results from that survey are still being rolled out in papers and presentations. But just as an overall summary, when we're looking at information about trans folks and healthcare, we're seeing that even though 81% of trans people surveyed had a healthcare provider, 45% of people surveyed responded that they had at least one unmet healthcare need over the past year. And over 10% said that they had had a case where they needed to go to the ER, they were sick, they were hurt, and they didn't because they were trans. And I think that really just gives us a glimpse into the barriers that people face when accessing healthcare settings, that you can be really unwell, that you can really need care, and that you're not going to get that care because you're afraid of how you're going to be treated in those systems. And not only do those barriers to healthcare spaces exist, but barriers to good health exist. There's lots of research out there on trans people and health. I'm not going to go through all of the stats, all of the healthcare disparities. First of all, because there's a lot of it. Secondly, because I don't think it actually does us a lot of good in this space to talk about rates of cancer or rates of mental health issues, but to just say that they are there and look at why. So that's the real question for me. Why do people experience lower health, worse health? And I think that really gets back to this point of stigma, where you're experiencing stigma in your family, you're experiencing stigma in housing, you're experiencing stigma in education, you're experiencing stigma in healthcare, and all of that impacts health and well-being. And what I'm really interested in here then is what we can do to improve health and what we can do to build health within trans and non-binary communities. If you want to go on to the next slide. So in 2016, Planned Parenthood Toronto worked with a committee of trans and non-binary youth to speak specifically around sexual health, but also health more broadly, and what providers can do to create positive and affirming healthcare spaces for trans and non-binary youth. And they came up with these 5 points that I think really hit a lot of what we can do to build better health for trans and non-binary communities. The first point, as you can see, is around language. We talk about pronouns like at the beginning of this presentation where we all introduced our pronouns, and they're a really good start. I'm glad that we're talking about people's pronouns. I'm glad that it's becoming common discourse to ask for people's pronouns and share ours, but pronouns aren't the end point. It's more broadly about using language that validates people's identities, about the terms they use for themselves, for their relationships, for their identities, for their bodies. For example, when we're talking about health, when we're talking about things like pap smears, instead of talking about vaginal exams or cervical exams, talking about internal genitalia, talking about the language that people prefer, and asking them, what are the words you use for your body? Because I can't sit here and give you the right term, the term that's going to work for everyone. Only people can speak to their own experiences and the terms that resonate for them. So saying, what is the language you use to describe yourself? And maybe that is vagina, maybe it's frontal, maybe it's internal genitalia. You won't know until you ask. And those conversations can absolutely be awkward, but it's much more awkward to find out that you've been using alienating terminology, that someone's no longer coming to you for services or support, and not having known in that moment. The second piece, which I think connects really strongly to language, is about validating identity and checking your assumptions. And I think that is really basically just about seeing people as they are and not who we think they are because of our stereotypes, because of the ideas that we come into our work with, because we all have ideas, we all have biases, but saying, okay, who are you as a whole person? How do you want to be seen? How do you want to be recognized? How do you want to be held in this space? And moving forward with that, even if it doesn't align with what we think we know about a person. The next point is around inclusive education. Whether we're working in healthcare or social services, we are educators. We're working with people to expand knowledge, and we're also working to expand our own knowledge. So part of that is about providing education to clients, to making sure that people know what services and supports are available. It's also about educating ourselves. What are the resources you have? What are the things you don't know and you need to do more information about? If you're in a position, it's also about building knowledge at an organizational level. So it's great if you as an individual person or an individual service provider are trying to build your knowledge and be a great person, But if your organization doesn't support that, if your board, if your leadership, if your reception, if your healthcare providers, if your social service workers aren't echoing the same trans inclusive sentiments, then it's really not creating a fully affirming space. So advocate for that organizational and institutional change. So what happens outside of the walls of your organization as well? Working also to build that supportive environment. And part of that is about physical environment. So what are the images in the room? What pamphlets are available? What language is being used? But also structurally, what washrooms do you have available? Who do you see present in the space? What's on your intake forms? And really trying to look at those pieces from a trans inclusive lens. And then the last point is about making this the standard of care. Trans inclusive care shouldn't be an exception to the rule. It shouldn't be an add-on that you tack on when you think you have a trans person in the space. It should be integrated throughout your care with all clients, with all service users, with everyone in your space and everyone in your life. This isn't just about our professional lives. It's about how we treat people out in the world, how we work to advocate for change, systemic change that can increase health more broadly and mean that people are getting the supports and services they need before it reaches a crisis point. I think the last thing I want to add is what Nadine already spoke to, which is that this is an intersectional approach. This isn't about trans people in isolation. This is about trans people who are also Black, Indigenous, or other people of color. It's about trans feminine people. It's about trans people living in poverty, trans people who are HIV positive, who are substance users, who are struggling with all of the various other systems that oppress and harm, and really recognizing people as their whole selves and not just in isolation. And I think that that's all I've got for now.
Anna, thank you very much. I found the discussion about language particularly illuminating. So thank you for that. And we will come back to you as part of our discussion at the end. Tuana, could we go over to you now, please, and talk to us a little bit about stigma and tuberculosis.
Just realized I was on mute. Thank you, Cliff. I'm cognizant of the time, so I will get things going. So like I mentioned before, my name is Tuana, and I'm a member of the TB project team, which is a project funded by the Public Health Agency of Canada, alongside my amazing colleagues, Jessica Kwan and Shafiq Armstrong. We were tasked with looking at the link between TB care and newcomers. So as part of the project, we spoke to various people. We spoke to individuals in high incidence TB countries, healthcare providers, settlement agencies, and as well as members of just the general public. And the underlying case was clear. There is a direct link between stigma and TB care. I want to start off by saying that we can't understand tuberculosis without understanding stigma. And I want to be even so bold as to say that stigma is more of a disease than tuberculosis is. With tuberculosis, we know how to prevent it, we know how it's transmitted, we know about the diagnosis, and we know how to treat it. But with stigma, well, I think it's very important to acknowledge a lot of the work and the progress that we've made with understanding stigma and a lot of the research that has come out, particularly in the last couple decades. We know more about the bacterial infection about TB than we know about stigma. And I think it's very important that we're having this panel today to discuss stigma. In the case of tuberculosis and stigma, there are many, many impacts, and I've just listed a few here. So the most obvious ones, of course, are on individuals who have TB. There's that fear of seeking care, the fear of being perceived as unclean, infected, and dirty. There's the impacts on the type of care received. From the project that Jessica, Shafiq, and I worked on, we did see that healthcare providers can have biases, and those are rooted in stigma, and that can have a huge impact on the quality of care that is provided to individuals with tuberculosis. There's also the impact of stigma on acknowledging the diagnosis, and that's rooted in the history of how individuals who had TB were treated in the past in terms of them being placed in sanatoriums. And of course, there is the impact on initiating and continuing treatment. There are also a lot of indirect impacts of TB-related stigma on care. So as the previous panelists discussed, stigma is very closely related with the social determinants of health, and we can't separate the two. So some of the more indirect impacts of stigma include the ideas of social rejection and isolation. And this is, very, very, very large impacts on both individuals' physical and mental health. Individuals who are stigmatized because they have TB live in loneliness, isolation, fear, and these individuals can be viewed as tainted or lesser. And this can create a negative cycle by leading to internalized stigma. We know that even when someone has been treated of tuberculosis, this can negatively impact their self-image, and there's still those lingering aspects of discrimination and isolation. From the literature and from the project that we work on, we know that the primary causes of TB-related stigma are based in perception. So there's the perception of the risk of transmission and the perception of having TB, or even being accused of TB, is linked with poverty, low social class, and other stigmatized diseases like HIV and mental health. And again, I want to mention that some of these perceptions are rooted in the history of how people with tuberculosis were treated, being blamed for having the disease, being placed in sanatoriums, and generally just being ostracized from their communities. And while our knowledge of tuberculosis has advanced, we know quite a bit about the bacteria tuberculosis. These perceptions and the impacts that these perceptions have remained. Miranda, can you go to the next slide, please? Thank you. In terms of eliminating stigma, I want to mention that education and awareness are important. But I also want to mention that it's important to go beyond just the base of providing education and awareness. I think it's important, and again, this is something that came out of the TB project, is that education and awareness need to be delivered to the appropriate audiences. And those include healthcare providers, high instance communities, and the general public. And I think beyond ensuring that the education and awareness is provided to the appropriate people, is ensuring that the education and awareness are tailored to the audiences that they're being provided to. It's important that the education is culturally appropriate, it's understandable. And I think this is something that really did come out of the project, was that the education needs to be delivered by a trustworthy source, and the audience in which this education is tailored to, they need to believe in the credibility of this education. Eliminating TB-related stigma also requires a multifaceted approach. We don't talk about stigma nearly as much as we talk about the other diseases themselves. And this includes TB, HIV, mental health, all of the other diseases. We speak about these, but we don't speak about stigma as much. And I think governments, healthcare providers, researchers all need to emphasize the role of stigma in how care is provided. And I think having discussions like the one we're having today is a very, very good start to that. And finally, I'd like to end off by saying that stigma reduction should be a routine component of health service delivery. And that includes having healthcare providers actively engage in these conversations with their patients. And perhaps that means that, more training or education on having those conversations needs to be provided to healthcare providers. So I will wrap things up there and pass things over to the next panelist.
Great, thank you, Tuana. Kyle, we are going to go over to you and then we're going to follow you with Mandana. We are down to our last 12 minutes. We may be able to eke another 2 minutes out of the webinar just for a wrap up. So Kyle, Mandana, about 6 minutes each. Kyle, over to you, please.
So I think the most common misconception that addiction has is that it's a choice, that people can stop using drugs when they want to. Addiction is complex. People develop addictions because of many reasons, including events in life, trauma, chronic stress, environmental factors, mental well-being, thoughts, feelings, and mental illness, genetics, and biology. Stigma for me is very personal. I was an intravenous drug user for 17 years. I've felt stigma most of my life. You know, being an outreach worker and being somebody that's had that lived experience, you know, sending clients to the hospital, they feel the stigma. You know, I send them for any type of health care and they're worried that, you know, they're going to get that red line around them that states that they're an addict. They're worried that if they reach out and to admit to the world that they're an addict, that people are going to judge them, that they won't receive the same health care. And that is probably one of the scariest things, because what that creates is somebody that's in their addiction and they're hiding it from the world. So they're using alone. They're spending their time alone because they don't know who to reach out. And, you know, as their disease progresses, they don't know how to reach out because they're scared to talk about it. It affects them trying to have a job because people don't want to hire an addict because of the stigma surrounding it. Are they going to rip them off? Are they going to steal from them, right? Or are they going to act out? And with the job, it also comes as housing. Somebody shows up and that's an addict, they don't want to rent to them because they're scared that, are they going to turn it into a trap house? Are they going to destroy my home that they're renting from me? There's so much stigma around it, you know. My own family, I remember my mom, when I came out as an addict, she was scared that people would look at her and judge her. Where did she go wrong? Why am I an addict? What was my life like? What created this? How was it her fault? I think that we need to remember we can't generalize people's experience. Living with addiction has so many different paths that bring them to a life of addiction, you know? And I think that the last thing I really want to touch on is when people are reaching out, looking for services to be helped, you know, parents, you know, it's hard for them to reach out because they have that child at home. And they're scared if they reach out that those flags are going to go up right away, and that their children are going to be removed, or that the neighbors are going to be watching them, or the police, et cetera, when all they want to do is ask for help. And I believe that the longer that there's stigma surrounding all of this, the harder it is for these addicts to reach up and ask for help. The harder it is for them to find a job, to find a home, and to find their lives and where they belong. You know, and that's receiving the same care as everybody else. Thanks.
Kyle, thank you very much for sharing some of your own personal experience and also for giving us some insight into stigma and its relationship to addiction. So thank you for being here this afternoon. Mandana, over to you to talk to us a little bit about stigma and its relation to cervical cancer.
Thank you so much, Cliff. And also I wanted to thank everyone who is attending this webinar today. I thought it's really good for us to start from the word stigma, and I know that it has been defined, but as everyone knows, Erving Goffman coined the term stigma. But before that, during the Greek time, the term stigma was originated from the Greeks, and it means bodily signs designated to expose something unusual and bad about the moral status of the signifier. So I think this is really important to understand some of the conversation and information that other member of the panel was communicating in terms of how the feeling of shame, guilt propagates through the stigma. It is also important to know that there are different kinds of stigma. And I think even though the other members of the panel gave examples, but from a theoretical point of view, we need to know that the research health-related stigma has been categorized into 3 types. There are the enacted stigma, which basically means actual experiences of discrimination, such as refusal of health services, employment, or housing, what was discussed by the previous panel. The second one is the anticipated stigma, and that refers to the fear of judgment by others, family, friends, co-workers. And finally is which is the worst one, is the internalized stigma, which is really the acceptance of those perceived social condemnation and which subsequently leads to the self-stigmatization. The reason I'm putting those there, because the interventions that we can propose will differ on each level in order for us to better tangle or address the issue of stigma and how we can actually eliminate it. So if you start by defining a stigma as an attribute or label that sets a person apart from others and link the labeled person to undesirable characteristics, then why are we talking about cervical cancer? Cervical cancer is also considered as a sexually transmitted disease because of HPV, which is, or human papilloma virus, which is sexually transmitted, and it is the primary cause of cervical cancer. So as a result of that, many people would avoid going for a screening because they don't want to actually be labeled by their family, friends, or the society at large as people who have been engaging in immoral kind of behaviors. In Canada, efforts have been done to screen women for cervical cancer, and this has led to declining mortality rate. However, screening rates remains quite low among certain subgroup of women, including immigrants, and that places them at a higher rate of advanced cervical cancer and poor health outcomes. And for the extreme case, death. We know that immigrants are heterogeneous population, and even among this group that the screening is low, there are certain subgroup of immigrants that have more challenges in accessing cervical cancer. The rate of cervical cancer screening has been quite low among women from regions with high Muslim populations, such as South Asia, Middle East, and North Africa. Immigrant women experience difficulty accessing sexual health information and cancer screening services, which is mainly due to systemic barrier that they face. These includes misconception and stigma about cervical cancer as being a sexually transmitted infection. Cervical cancer is linked to sexuality and taboo behaviors like premarital and casual sex, promiscuity, and infidelity. The portraits of cervical cancer as symbols of immoral and irresponsible behavior is a major hindrance for many of the women who are coming from Middle East and South Asia countries, as well as the North Africa, in terms of undertaking this. The perception that sexually transmissible infections are typically occur during voluntary and avoidable sexual activity promotes the belief that contracting HPV is the bearer's responsibility, and a sentiment that is strongly associated with stigmatizing attitudes. Cultural taboo surrounding female sexuality and sexual activity, like modesty, premarital virginity, and entrenched gender norms and stereotypes associated with STI is another factor that hinders access to cervical cancer screening. The gender imbalance or double standards around sexuality, in which women are judged more severely for engaging in sex outside of the marital context, leaves women at greater risk for experiencing STI-related stigma than men. And one of the panel members actually alluded to that factor. Historically, women have been viewed as vectors of STI and consequently blamed for both acquiring and transmitting the disease. The third factor that has been identified in the literature and through the research of mine and my colleague, Dr. Arshay Lofters, is the low HPV and cervical cancer literacy, which is often due to prevailing discourse that discourages open dialogue about sexualities. The socioeconomic living conditions and language difficulties are also have been identified as contributing factor for low undertaking of cervical cancer among immigrant population. And finally, the access to primary care providers. The majority of the immigrants who are actually coming to Canada, they lack to have primary care providers. Many of them actually access services when they have a health problem. In majority of the countries, from the low or middle income countries that our immigrants are coming from, they have to pay for their own health. It's not a universal healthcare system that they have. So as a result, they mainly only use health services when there is a sign or symptoms. So it makes it very difficult when we talk about a screening and when they are not really experiencing any symptoms for them to actually come and seek healthcare. I was also asked to provide some stigma reduction strategies that could actually overcome this issue. And I believe that if you go back to the 3 different types of stigma, the enacted one, which really is nothing but the norms and values of our society at large, needs to be targeted. So in order for us to effectively promote open communication, disclosure, prevention, screening, and treatment of cervical cancer, interventions are needed that could change the prevailing attitudes and norms that is being held by our society, as well as the way in which the issues pertaining to sexually transmitted infections are communicated by institutions such as the media, public health, and also healthcare agencies. A stigma associated with HPV and cervical cancer can be demystified by highlighting that they are more common and subtle than generally believed. For example, if we could actually share with people that most men and women, about 80% of sexually active people, are infected with HPV at some point in their lives, but most people never know they have the virus because there is no sign and symptoms, it may make people more aware of the situation. So by reframing it and making it into a legitimate public health issue, rather than just categorizing and blaming certain people for certain behavior, then it becomes much more normal and it demystifies what the fear is about it.
Mandana,
yes?
Sorry to interrupt. Can I ask you, we're just over time, can I ask you to sum up your section in a minute?
Okay, then to sum up my section is that all our intervention should be really targeting into normalizing, demystifying these sexually STI-related conditions. And as such, we would be able to bring forward people who are suffering from this situation. So therefore, people can understand we are all the same. There are a few other things, but I think the time doesn't allow me to go into them. Thank you so much for the time. Thank you.
Thank you, Mandana. So first, I want to thank all of our panelists for participating in the webinar this afternoon about stigma and various conditions that they are particularly focused on in their communities. I'm certain you'll agree with me that there were numerous themes that we heard from all of the panelists. Certainly, we heard about a stigma cycle. Certainly, we heard about the importance of language, of being labeled. We heard words like clean and dirty in a number of from a number of the panelists. A number of the panelists talked about the rejection and the isolation that people can feel because of stigma, and how that in fact can drive the stigma cycle. We certainly heard from a number of panelists the cross-stigma impact, the intersectionality of stigma, and how stigma plays out in a number of different ways, in a number of different factors. Certainly, some panelists talked about a lack of emphasis on prevention, on the blaming nature of stigma. We certainly as well heard that stigma can be very personal. It can have a huge impact on an individual. It can cause fear. It can cause them to go into hiding. It certainly reduces engagement and interactions that person may have with the healthcare system. In relation to their family, in relation to their friends, and that in fact, stigma can have an impact on family and friends as well. I believe in the video, we heard a person say that in fact, stigma is the deadly disease. And I think that's where we can leave the conversation today. There have been great advances in medical care, in clinical care. Stigma remains with us. And in fact, I think what we can say is that in relation to all of these conditions, stigma is in fact that final barrier, that deadly disease that we need to be able to tackle and we need to be able to eradicate if people are truly going to be able to achieve and maintain good health. So once again, a very big thank you to Nadine, Anna, Tuana, Kyle, Mandana, for taking the time to be with us this afternoon and sharing their thoughts about stigma. Thank you, Miranda. Thanks to the Alliance for Healthier Communities for giving us this platform. And it's also very clear to me to also check out some of the recommended resources that are a part of the slide deck that will be made available on a number of different websites. And we also have included ways for you to contact any of the individual panelists on the next slide, and to learn a little bit more about the agencies that they are working with. So thank you again. It's clear we will need a part 2 on stigma. Thank you very much for taking the time to join with us this afternoon about this important topic. And have a good afternoon.